1. Over-reliance on fluids. Excessive fluid administration can cause harm, particularly when vasoactive agents could improve perfusion earlier, reducing the risk of fluid overload. Waiting too long to initiate vasoactives may worsen outcomes. Early use of agents like norepinephrine in vasodilatory shock can be fluid-sparing and beneficial. Choosing the wrong vasoactive agent can worsen outcomes. For instance, dopamine is associated with higher mortality compared to epinephrine or norepinephrine in pediatric septic shock. Epinephrine is preferable for myocardial dysfunction, while norepinephrine is better suited for increasing systemic vascular resistance. 4. Failure to monitor for adverse effects. Catecholamines can lead to tachycardia, arrhythmias, and myocardial oxygen supply-demand mismatch, which can exacerbate shock if not carefully dosed and monitored. Five. Inadequate multimodal monitoring. Relying on blood pressure alone is insufficient. Perfusion parameters, urine output, lactate levels, SCO2, and hemodynamic monitoring, e.g., central venous pressure, cardiac output, should guide therapy. 6. Failure to recognize catecholamine toxicity. Excessive dosing of catecholamines, without proper weaning, can lead to unresolved shock and organ dysfunction, due to their adverse metabolic and immunologic effects. Seven. Underutilization of non-catecholamine agents. Milrinone and levosimendan can be valuable in persistent cardiogenic shock, but their use requires careful monitoring of blood pressure and volume status to avoid hypertension. Eight. Inadequate source control. Vasoactive agents alone are insufficient. If there is an underlying infection or obstruction, e.g., abscess, tension pneumothorax, early source control is crucial for successful treatment of shock. 9. Inappropriate use of steroids. Hydrocortisone should only be used when fluids and vasopressors fail to restore hemodynamic stability, and its effects can vary based on individual patient characteristics, e.g., gene expression profiles. (10) Delayed use of ECMO. For patients with refractory shock, unresponsive to medical management, early consideration of extracorporeal membrane oxygenation, ECMO, may be life-saving, especially in cases of severe myocardial dysfunction. However, the decision to initiate ECMO must be carefully weighed based on the individual risk-benefit profile.